Assalamu alaikum. Our last session will be talking Professor Nadir Al-Rawi. He's a professor and consultant in oral histopathology, and he holds a PhD in oral and maxillofacial pathology. Also, he is a professor at the University of Sharjah. His presentation will be Salivomics, Doctor, unlocking the secrets of saliva and the oral health, and also in medicine. So, welcome, Dr. Nadir. I hope that you will take your time.
Thank you very much. First of all, I would like to thank the organizing committee for inviting me to attend this conference and to present my presentation about salivomics. Actually, it will be in alignment with the mission of the conference, because it will bridge the gap between dentistry and medicine by knowing the benefit and also the significance of. I have one.
You have one?
Yeah.
Okay.
Significance of saliva, which is not just a spit, just we all know. So first of all, we will talk and we will have. How can we move this? How can we move this? Yeah. So my. From here, yeah. So first of all, we'll talk about why we are talking about saliva and why saliva is considered as a diagnostic fluid, and also we will talk about the omics and its application in the different field like proteomics and metabolomics and microbiomics, and also we will have some small information or short information about the point of cares and salivary biomarkers. So first of all, what is what is this? Okay, why saliva? First of all, you all know that our diagnostic gold standard is a serum or is blood, but usually saliva have some advantages that could be used because of its safety and non-invasive procedure, and also it shows a great diagnostic potential, and also it can be easily collected, so the patient compliance would be good, and it contains most of the biomarkers that present in the blood. You all know that saliva is usually secreted from 3 pairs of major salivary glands and hundreds of minor salivary glands, and its main function is not only for lubrication or for digestion, but also it can be used for screening and for diagnostic process and for prognosis and also for treatment evaluation. Now, each salivary gland might have its own annihilates. For example, parotid gland have these annihilates like amylase or agglutinin and cystatin and lysozymes. And the submandibular gland might have also immunoglobulin and mucin, and the same thing for the sublingual gland. Beside these annihilates, they have the mucin, and we have different annihilates from the shedding epithelial cells that could be mixed with the saliva, like the DNA and the RNA, the microRNA, or the non-coding messenger ribosomal nucleic acid, beside the immunoglobulins and many other annihilates. So these are the salivary composition. It's not working? Okay. So when we talk about salivary biomarkers and the research all over the world, you can see here these are the data that was extracted from Scopus database. And you can see from 2005 until 2025, and look at the leap and the increase in the interest of researchers in doing salivary research. And you can see that the number of research in 2024 reaching about 800 59 research regarding the salivary biomarkers. The other thing is about the University of Sharjah. I'm from University of Sharjah, and you can see also the marked increase in the number of salivary research and salivary biomarker research, and mainly started after the establishment of Sharjah Institute of Medical and Health Science. And usually these needs a lot of high throughput machines and many devices that are not available maybe before 2005, and we will talk about this in the upcoming slides. Now, what are the challenges in the as a salivary biomarkers? Not all molecules detected in the blood could be valid molecule for as a salivary biomarkers because of its low concentration, or sometimes it could be because of the variability of the saliva composition, and also the detectability, because some are beyond or below the detection limit of the kits that we used as for analysis of the molecules, and it could be because of the matrix interface. And here you can see, for example, the ways of collection of saliva. Most of the researchers do not know, especially in the medical field, do not know when and how or why we use this saliva, for example, in the form of whole saliva or gland-specific saliva, whether we need it as a stimulated saliva or unstimulated saliva. So here you can see the salivary collection will be used, and each one has its own indication. And usually, saliva needs a pre-treatment before analysis. So, for example, for the unstimulated saliva, we need centrifugation, and for stimulated saliva, we may need filtration and ultrafiltration and dialysis. And then in analysis, for example, in unstimulated saliva, we can use, for example, the electrophoresis or the mass spectroscopy in its different types. And in stimulated saliva, we can use also the electrochemical method for detection of the signals of the molecules if it is present in the saliva. This is for the whole saliva, but sometimes we might need some saliva from specific specific gland, major salivary gland, like for example the parotid gland. And in this condition, we need to have a cannulation in order to extract only the saliva that's coming from the parotid gland. Or it could be from submandibular or sublingual gland, or even from minor salivary gland. So these are the methods that needs to be known and needs to be familiar for the researcher in order to conduct his research in a correct way. And usually the storage is very important. If you are dealing with a protein, for example, or for hormones, or even for DNA and RNA, defreezing is very important. And also, the protease inhibitor, for example, for a protein is very important in order to prevent the degradation of the protein that you are going to assess. And the immunological method is the most common way used for detection of these molecules, including the ELISA test and many other methods which you are familiar with because it's dealing with the blood, like radioimmunoassay or Western blot or something like that. Now, another thing which is very important is, is about the promise of saliva as a biomarkers in certain conditions. For example, hormone measurement. We all know that in saliva we might have the cortisone, and we have many other hormones that can be detected and can be assessed. And it has its diurnal variation, and usually the best time for collection of this saliva may be in the morning at 11 a.m., for example. Infectious disease. We all face the SARS-CoV-2, for example, infection, and saliva was used in our research center and also in many other research centers all over the world in order to detect and to find an alternative method instead of the nasal swab, nasal swab. And we can use also the saliva for drug monitoring and many other oral diseases. Okay, now what are the alphabets for salivary proteomics? Now we will start with the proteomics. Omics is usually a family that deals with the component of the cells, whether in the cytoplasm or in the nucleus. So the alphabets for for the proteomics is usually the protein, the messenger RNA, and the microRNA. So these are usually the main domains where the proteomics is usually used to detect these molecules. And we have also the metabolomics, where there is a metabolism, and this metabolism lead to, for example, the fragmentation of these molecules to amino acids or many other molecules, and it also can be detected in saliva. And we have microbiomics, which is also used as an alphabet for the salivomics. Okay. Now, if you see here, for example, in salivary proteomics, this is the increase in the number of research until it reaches this number. It's only from one database, or the information is coming from one database. And if you can see here, for example, the most studied proteomes, and our research center is also doing this work since the establishment of Sharjah Institute of Medical Center. And you can see here, for example, the cystatin, the interleukin-6 and interleukin-8 can be detected in saliva, in addition to this matrix metalloproteinase, defensin, and heat shock protein. And all these are usually considered as part, maybe a potential biomarkers for oral squamous cell carcinoma, which is the most common oral cancer in the oral cavity. The other thing, in periodontal disease, we have also a specific proteins or proteomes that can be detected in saliva. Like, for example, the matrix metalloproteinase or the interleukins or maybe the C-reactive protein. Now, the most studied salivary proteomes in systemic disease, so it's not only for local disease, we can see the proteomics can detect, for example, the cardiovascular disease in terms of measuring the C-reactive protein or troponin, and also in diabetes, we can detect amylase and cystatin and Sjogren syndrome. We have these proteins, you can read it, because I don't have time to mention it, and hormonal monitoring, for example, for testosterone and estrogen and progesterone, and for the infectious disease. All this needs technological advancement by the presence of mass spectroscopy, ELISA, and also the liquid mass spectroscopy, which is able nowadays to detect these minute materials or that cannot be detected before. The metabolites also can be detected in the saliva, and you can see here the amount or the number of research dealing with the salivary metabolites. And also we have some dental, oral and dental diseases where these metabolites play a very important role to monitor the progression of disease, for example, for periodontal disease, or to detect the carcinogenic environment for the dental caries. Also, in systemic disease, we have some metabolites that are able to detect and monitor the progression of diabetes mellitus, for example, Alzheimer's disease, cancer, infectious disease, and cardiovascular. Also, we have some high throughput machines that detect these metabolites, like nuclear magnetic resonance or mass spectroscopy or liquid chromatography, gas chromatography. The transcriptome is another omic family, and we have to know that in saliva only, we have more than 3,000 messenger RNA in cell-free saliva. So we have a good amount of these molecules to be studied and to be detected. And as you can see here in oral cancer, we have the messenger RNA that overexpressed in oral cancer, or microRNA, which is usually a hot topic nowadays for measuring the dysregulation and progression of metastasis. In systemic disease, many other cancers can also be detected and monitored by the measurement of the microRNA or messenger RNA like this. And in other systemic disease, you can see here the MER or the microRNA or the MERNA are usually a hot topic for measuring the progression and detection of many systemic disease like this present in salivary transcriptomics. And here in transcriptomics, we need another methods of measurement like microRNA sequencing machine, qRT-PCR, and exosomal RNA studies. fortunately, in our research center, all are present, which enabled us to do the research in high flexibility. In microbiomes, I think I will skip it because I don't have time. And this is another topic.
دكتور نذير.
A lot of, yeah, we have the...
استعجل عيني.
Yeah, okay. So in oral cancer, we have also some bacteria that usually comes as a result of dysbiosis. And also we have many other systemic disease where the oral microbiota may be linked with the systemic disease, like with atherosclerosis or with the diabetes mellitus, and also with rheumatoid arthritis or with respiratory infection. So I want to go for the conclusion and to see why is saliva is important. So this is the genomic study, and as you can see, and we have the point of care. This is very important. Since we are dealing with the saliva and with these biomarkers, we will be able to put the saliva-like serum as a point of care, and especially if we have tools for development of this point of care, like microfluidic application or appliances, and the micropumps and electrochemical sensors. So there is some sort of link between the electrical engineering and also the medicine in order to reach the point of care. And we have now developing this microfluidic device in certain diseases in our center. So it needs these microchannels and microsensors in order to separate the saliva and also to treat the saliva, and it will be just like a lab on chip for diagnosis and also for monitoring the disease. Okay, this is the sensors that is developed using the micro and nano electromechanical sensors, and it is usually provide a very, very sensitive detection limit for saliva. So saliva is oral cavity guardians, and usually it can be used to advance the precision medicine, and it can be used as prophylactic or provide prophylactic and therapeutic strategies. And the salivamic era will revolutionize the salivary diagnostic and contribute to a new social and medical direction worldwide. And with this, thank you very much.
Assalamu alaikum. I am Dr. Hussein Mutlaq, consultant pediatric neurology, Barjil Hospital, Abu Dhabi. The second speaker, I know it is the end of the day and end of the session. You are tired, so we'll go without any further delay. The second speaker, Dr. Munaf Al-Kassab. He is senior consultant pediatrician. He is a clinical assessment professor at University of Sharjah. He's a consultant at Dr. Sulaiman Al-Habib, Dubai. His talk is going to talk about the asthma phenotype and management.
Assalamu alaikum wa rahmatullah. First, I would like to thank the scientific committee for accepting my presentation today. I am working in Dubai since 2.5 years. And before I was working in Saudi Arabia for 17.5 years. My special interest in pediatric asthma and allergy started in 2008, and since 2013 I established pediatric asthma clinic to be more close to those patients. So phenotyping is trying to bridging the gaps in the management of pediatric asthma. So this is a common case presentation, a common scenario of a patient coming with a chronic dry cough, without wheeze, without any other signs of asthma like chest tightness, and also pulmonary function test is normal, everything is normal. So he's labeled as psychological cough or other cough. We will see what is this phenotype later. Asthma means the panting person. And when Alexander the Great invaded India, they found them treating asthma by smoking herbs contain anticholinergic effects. And since the 1500 AD, just before 500 years, the smokes was used to treat asthmatic patient. And this is called Dr. Tucker asthmatic specific. It contained cocaine to treat patients with asthma. They were very happy at that time, the asthmatic patients. And then in 1890, this is asthmatic cigarettes. It was sold, but it is forbidden for children below 6 years. So 8 years he can smoke this one to treat his asthma. Also in 1930s, it was a very familiar to smoke herbs to treat asthma. Asthma was considered as a psychosomatic disorder. It's not a pulmonary disease. Those who are having asthma, one of the famous physician in 1870, he treated the son of the United States by asking him to smoke tobacco. Okay, until Rakuman was the first one who understand asthma well and start the term of phenotyping. He said there is extrinsic asthma, which means there's an allergen coming from outside, and intrinsic asthma, which means when you have an infection and having a symptoms, or you have a fear or psychological thing, this is called intrinsic asthma. It's a very common disease in UAE, around 10 to 12% of children, and this affecting the life of children. Always we are looking as a patient or a health giver, looking to the exacerbation, but we are not looking here to the chronic inflammation, which is with time leading to remodeling and changing in the airways. Okay, so pediatric asthma is a most common inflammatory disease of the airway in children, and characterized by cough, wheeze, and shortness of breath. Specific evidence indicate that asthma is heterogeneous disease and different from one to one. Before, asthma was a single diagnosis. Now, asthma considered as a syndrome caused by a different phenotypes and different endotypes, which means different pathophysiology. So, phenotyping started in adults, but then they said that pediatric population is different, and even phenotyping is different in pediatrics. Phenotype is a cluster or a group of patients sharing certain variables, certain demographic, certain biochemical or pathophysiological things. So simply, this is the cascade for a typical atopic asthma, the pollen pass, the antigen-presenting cells catching it to Th2, and then to B cells produce specific IgE, produce interleukin 3 and 5, and there is an immediate reaction and late phase reaction, making eosinophil recruitment and producing interleukin 3, 5, and 13. While here, let's see in viral-induced asthma, how the pathophysiology is different. On the left, this is a normal, what is the mark pointer? دبل كليك على الأخضر. Where? Okay, thank you. So here in the left, we can see the normal persons. When anyone having a viral infection, there is this increased interferon gamma and up regulation of the interferon-stimulated genes, so there will be clearance of the virus. While in asthmatic patient, we can see here that impaired interferon response, predominant Th2 instead of Th1, and low interferon gamma. So this leads to cell more infection, uncontrolled viral infection, cell necrosis, and exacerbation. So this is, now we have two different pathophysiology. And also the same, what will happen also in viral infection, there is stimulation of the sensory nerve, parasympathetic nerve activation, and acetylcholine production lead to bronchospasm. So now we have two different pathophysiology. And for the third one, for the exercise-induced asthma, also the pathophysiology is different. Again, it's a different endotypes, different phenotypes causing a syndrome of asthma. So asthma is a syndrome rather than a disease, single disease entity. Classification of phenotypes, we can classify asthma according to age of onset, natural history, severity of asthma, mild, moderate, severe, triggers, according to the triggers, as we will see in the next graph, exercise-induced, and so on. Is it the type of inflammation? Is it eosinophilic, 80%, or neutrophilic, 20%? According to the exhaled nitric oxide, also it's classified. So all these making us more narrowing or classifying the patient. This may lead to the better tailoring of the treatment. So obesity and asthma. Obesity before was considered as a comorbidity of asthma, but since 2013, it's considered as a different phenotype. It's a phenotype of asthma. Okay, so let's come. Why asthma? Why obese patient could get asthma, even if he's not a true asthmatic? There are many theories. It could be mechanical, increased abdominal pressure, causing reduced chest expansion, and with time lead to bronchial remodeling of the airways. They found also what's called desynapsis. The desynapsis of 6 cohort studies, they found that the dimension of the airways in relation to the lung tissue differs in obese than the non-obese children. Also, and this is very interesting, they found that the obese patient takes breathing with tidal volume larger than the normal thin persons. And this leads to deposition of more micro air pollution in the airways of the obese patient, and this leads to chronic bronchitis. Also, the pro-inflammatory marker, fat accumulation, high BMI, these lead to hypoxia, focal adipose site necrosis, and these lead to recruitment of macrophage, lead to high blood level of leptin and other pro-inflammatory hormones. Leptin has a pro-inflammatory action, promote neutrophil chemotaxis, reactive oxygen, specific protection, natural killer, and phagocyte activation. And leptin receptors are expressed in the human airway cells, and it has been hypothesized that leptin may be related to airway reactivity. But the true mechanism, honestly, is not well understood. Genetic factor, 2 genes are identified, strongly associated between asthma and obesity, which is beta-2 adrenergic receptor and tumor necrotic factor, alpha. Hormonal factor, obese asthmatic children, oh my God, 3 minutes, okay. I will run. Microbiome is playing also a role, physical activity playing a role, also in obese asthmatic, steroid use in asthmatic patients. Now, if we put the asthma, classic asthma phenotype with obese asthmatic, we can find that everything is different. For example, if we do skin prick test for allergy, it's positive in asthmatic, but it's negative in obese. Fractional exhaled nitric oxide, it is high in asthmatic, normal in obese. Okay, IgE level is normal. It's low, normal in obese, it's high in classic asthma. And even for all the cytokines are different. And many of these are, the leptin, high leptin, when the body weight became normal, normalized, and so on. Pulmonary function test, and even asthma may disappear if they got the ideal body weight. Okay, I'll go through. This is very interesting. Now, what is the value of phenotyping? Now, at least they classified the 3 phenotypes of obese asthmatic. The atopic, true atopic obese asthmatic, they have a poor IC-ACE response. Even if it's atopic, he's atopic, he should respond to steroid. But because of obesity, steroid have a low response to steroid. Those with obesity and insulin resistance, and having a better response to inhaled corticosteroid and LABA, and those with dyslipidemia, who have dyslipidemia even in children, may gain benefit from cholesterol-lowering diet. This is all the classification of phenotypes according to the trigger, viral-induced, exercise-induced, and allergy-induced. And this is according to the Age group, transient early wheezer, usually they are preterm, viral-induced wheeze, not a true atopic, and resolve after 3 years. The non-atopic wheezer, chronic wheezer, yeah, the IgE is normal, no aeroallergen sensitivity, and also it is neutrophilic inflammation. Atopic wheezer, this is the true asthma, sorry, the classical asthma that you have high IgE, and this is usually have a long life as a treatment because it's considered as a chronic illness like hypertension. Severe asthma, everyone wants to dissect this form and classify it because severe asthma is the most difficult, dangerous, disturbing, or خلينا نقول يخلص الميزانيات مال المستشفيات هو السيفير أزمة 5 to 10%.
دكتور مناف 1 minute please.
1 minute? Okay.
1 minute.
إن شاء الله. Okay. This is the last two slides. The severe asthma they discovered before a few years one of the very important phenotype which is called obese girls with an early menarche constitute for a new phenotype which is the most severe phenotype of asthma. Okay. Sorry, this is the last slide. Okay. So this is the case that I present before. It's called CAF variant asthma. CAF variant asthma is a classic, one of the forms of asthma that don't have a wheeze, and with time they got classical forms. It is undiagnosed because of these symptoms. Finally, asthma phenotype is changing over time, could be multi-triggered, could be obesity-related, could be allergen-induced, and change with time from intermittent, mild, moderate to severe, and so on over the time. So in conclusion, identification of true phenotypes of childhood asthma is likely to improve our understanding of the pathophysiology, improve our ability to find new treatment targets, and individualize their therapy. And thank you very much.
Thank you, Dr. Manaf. Thank you.
Our last speaker for this successful day, inshallah, Dr. Wissam Ismail, consultant plastic breast surgeon, and he is a fellow of the Royal College of Surgeons in Edinburgh, and he is senior consultant in American Hospital, Dubai, and his presentation will be advanced in oncoplastic breast surgery. Thank you. Welcome, Doctor.
Sorry to, be a bit late for me, but I'll try to make it concise and specific. So, my name is Wissam Ismail. I'm a consultant oncoplastic breast surgeon at the American Hospital, Dubai. So, it's been a very, interesting journey. Graduating from Baghdad Medical School, and then I moved to UK, spent about 20 years, did all my training, became a consultant in Nottingham, and then 4 years ago I moved to Dubai, to the American Hospital. So, double click, okay, good. So, I have no disclosure, apart from Dr. Ahmed, he's a very good friend of my dad. They used to play tennis together in Nadia Said, and they were both dentists. That's the only disclosure. Thanks, Dr. Ahmed. So, breast surgery. Breast surgery has advanced for the last 30 to 40 years. It used to be very radical, very aggressive, but that has always changed for the last 30 to 40 years with the introduction of oncoplastic breast surgery. Everybody knows the Haltes procedure, so, whenever you get breast cancer, that's it. Get the mastectomy, get the breast out, part of the muscle, get all the lymph nodes out, and the comorbidities were huge. So I'm not going to bother you with the history, but the history of breast cancer goes back to about 20 years ago. 20 years, sorry, 2 centuries. All right, okay. Yes, good. So what is actually oncoplastic breast surgery? Previous surgeon, let's say previous breed for the last 40, 50 years, they used to do a breast cancer surgery, and if the patient requires any reconstruction, that is usually done by the plastic surgeon. My generation, as a new breed of oncoplastic breast surgeon, we are doing A to Z when it comes to breast cancer. So we are trained as a general surgeon and as a plastic surgeon to remove the cancer and reconstruct the breast, and we'll be involved for the whole journey from A to Z. So, what do we need to, consult the patient about? What is reconstruction? So we just want to restore the shape of the breast, mainly after breast cancer surgery. Now, mastectomy is only involved about 20, maximum to 30% of all the breast cancer that we do. We managed to save and preserve the breast shape and volume and functionality in about 70% of patients. How would you classify the breast reconstruction? So it's very simple. Either we use your own body tissue or we use prosthesis. And sometimes we used a hybrid technique by using your own body tissue and external prosthesis. So how do we treat breast cancer? Either we remove the cancer itself, or remove the breast if it's a multifocal, or we do bilateral mastectomy. That's especially for people who carries the gene mutation. BRCA1, BRCA2, Jewish Ashkenazi who's got 15% breast cancer as a genetic mutation. And, the challenges comes when the patient has a very high volume breast, and we need to remove the breast cancer, but also to give them a degree of symmetry. And that's where the challenges comes. We can do immediate and delayed breast reconstruction, depending on the oncology type, and that's why, breast cancer surgery is a very teamwork business. We cannot work solo, so we work heavily with the oncologist, with the radiation oncologist, with a lot of members of the team, and we have to meet every single week on the MDT multidisciplinary team to decide what is the best for this patient. And if the patient likely not to need radiotherapy, then we go straight from cancer surgery with immediate reconstruction. But if the patient really needs radiotherapy, you have to go for stage reconstruction, and we put a tissue expander in place as a bridging therapy. And that's the delayed reconstruction. Now, we're just going to go into more depth, but I'm not going to bother you a lot about those. The main types of two reconstruction, we use your muscles, your own fat and skin, or we can use like external prostheses, like implants and prosthetic meshes. We put it either above or below the muscle. Okay, so, as I said, the oncoplastic is a very evolving specialty, and it's developing every year with the new technologies, with the new techniques, with the new tools that we have to preserve the functionality and the shape of the breast. And the principles are very simple. We excise the volume. Where's the tumor location? What is the glandular density? And that's why we're heavily involved with the breast radiologist. So now we'll talk about the exciting bits, advances about the breast oncoplastic surgery. We'll talk about therapeutic mammoplasty, pre-pectoral implant. Many years ago, we used to put the implants under the muscle, but now we're becoming more challenging and more courageous. We put the implant on the skin with a coverage mesh. Even if the patient needs radiotherapy, that's not going to erode. Lateral perforator flap, we're going to talk about it in a minute, which we use, the muscles and the skin and fat, and they're rotated to restore the volume of the breast. Lipofilling, another exciting technique. It has a lot of heavy stem cells involvement, and this will regenerate the volume into the fat cells and gain blood supply. Right, so we'll talk about the therapeutic mammoplasty. So the patient had the left breast cancer, and you can see that's bruising from the biopsy, and the cancer was about 2-3 centimeters. And with the help of removing the cancer and doing a liposuction and concentrating that fat and getting into the breast, we've managed to restore this picture. And this patient, that's the scar there, and this is after 2 months of surgery. With a flatter tummy, we take the fat, and then we restore the volume of the breast cancer. And you can see that is the cancer, which is about 2.5 centimeters. Right. Now, this is a bit of a challenging case. This is a 27-year-old lady. And then she felt a lump, she didn't feel anything about it, and bang, it's a big breast cancer, triple negative, very aggressive. And she couldn't compose that she got cancer, she needs chemotherapy. So she got BRCA gene positive. Her mom died of a breast cancer, unfortunately. So we had to do bilateral mastectomy and reconstruction. And you can see that that's before surgery. And I did a hybrid procedure for her. We did the liposuction, we removed both breasts through what we call it infralateral incision. And we did a pre-pectoral implant. That means the implant and the whole mesh is in front of the muscle. And then we do the liposuction and get everything there. And that's the result after 3 months. That patient got married. She became pregnant. I went to her wedding. And then I've just seen her kid. That was like 3-4 years ago. It's very touchy. Okay, now, what is subpectoral implants? We usually still use the muscle to lift it up and get the implant reconstruction because we are worried that, the upper part of the implant can be shown as what we call it, animation, and we don't want to see that. So this lady doesn't have much of a volume of the breast at the upper pole. And again, bilateral mastectomy, she's a BRCA gene positive. In this case, was just a subpectoral implants and a mesh without using any volume replacement in terms of fat transfer. Now, this is a more challenging case. So this lady had a cancer just behind the nipple. And you can see there that she had an implant before, and it's still there as a cosmetic procedure. So again, on the first stage, we had to do a bilateral mastectomy. We have to remove both nipples. She's not G mutation, but she's got a very high risk of familial breast cancer. So that's on the first stage without a nipple. And then when everything heals up after 3 months, I had to create a nipple as a nipple reconstruction from the same flap and do a lipofilling and give her a bit of volume there that she was deficient in. And when everything is fine after that, we do a tattoo for the areola. So that's what we started with. And this is a bilateral mastectomy with implant reconstruction and nipple reconstruction. This is the lateral perforator flap. So the cancer is, again, it's in the upper pole, which is a bit unforgivable place. So we had to use the skin and fat from that area, flip it up after removing the cancer, and that's the immediate results. Then again, lateral perforated flap through a minimal invasive breast surgery. We stopped using a lot of scars. We doing breast surgery over like a 2 or 3 centimeter with the help of endoscopy, and now the introduction of the robotic breast surgery. Again, so that's heavily involved with my breast reconstruction. So we do very delicate liposuction, and sometimes we give the patient an advantage and give them like 6 packs if they want, give them a bit of definition of their muscles. But that's the fat streaks that we take out, and that's what needs to concentrate, and that's what goes into the patient afterward, aiming that we keep 70 to 8% of that fat as a blood supply. Again, that's lipofilling to breast. And, the stem cells in the fat, it does magic. So this lady had a big cancer there. We had to remove it through the scar, and then with the help of fat transfer at the same time, and doing a sentinel lymph node. You see the scars at the beginning, they're very prominent. But then this is after 6 months. Scars are hidden, scar on the axilla is hidden. This volume is totally replaced. This is like a small sebaceous cyst infected, has nothing to do with the breast cancer, but it was in the picture. Again, desmoid tumor, another type of cancer that stuck to the chest wall, and this is very, very aggressive. With the hybrid technique, removing the cancer, doing a fat transfer, lipofilling, that's the result after 1 year. Now again, we can combine different procedures with the fat transfer. And again, it all comes down to stem cells. Stem cell saves a lot of breast reconstruction in my field, and it really helps a lot. So this lady had if you can see, like a breast lift. This is a purely cosmetic. There's no cancer involved. So she had a breast lift a year ago in different hospitals. She wasn't happy, and she wanted another lift, but she doesn't want to use implants. She wanted volume as well. So we had to do a lipofilling, get some liposuction here, put it up there, and these are the results after 6 weeks. Now, new technologies when it comes to breast cancer, seed technology. Up to when I was in England about 5 years ago, we're putting a wire to find the cancer. That's not the case anymore. Now we're using different companies that provide us with a seed that can stay there for 6 months before the patient gets into like chemotherapy. And then we can localize the cancer in a very, very advanced way. Now, coming to patients suffering from breast cancer journey, you know, this is a very, very ugly picture. Patients shouldn't really have that. So this lady had a mastectomy, and she developed a radiotherapy. You know, she had to have radiotherapy, developed a very contracture. So we did a stage reconstruction, tissue expander. You can't see this redness at radiotherapy. And after that, we had to change it to an implant. And I'm just waiting for her to heal, and I'll create a nipple for her. Again, salvage technique. It goes on and on and on, depending on the technique. And really, it's a teamwork. Okay, let's go back. So again, that's a horrible LD that's gone somewhere else, and we've managed to salvage it with an implant and a mesh, you know, going from there to there. It's all about keeping the volume and the shape for the patient. And as I always say, breast cancer patients should not suffer. They should live a normal life. They should not wake up every morning looking at the mirror and just feeling ugly. Now, more challenging salvage technique, implant can get infected, implant, you know, skin can die off. And this is one of the interesting salvages that we did regarding what we call the rotator advancement flap. So what's coming up to breast surgery? Stem cells, you know, after cancer excision, we start injecting stem cells through the fat, and this is helping a lot. Biological matrix for volume replacement. So when removing the cancer, we start putting matrices. This is still on the research value, by the way. And then the next stage of our journey will be using AI to diagnose breast cancer through the CAT system, and this in the pipeline, and using robotic breast surgery. Thank you very much.